board certified plastic surgeon here at Revalla Plastic Surgery. We're going to talk about breast reconstruction today and all the different options. Now, the first thing to remember with breast reconstruction is you don't have to do it. And so there's always the option of doing nothing, but there's also the option of doing an external prosthesis that fits in your bra. So if this doesn't feel right of what you want to do, you can always stage reconstruction out and we can look at reconstruction options down the road. But today we're going to go over the aspects of reconstruction that we can do actually at the time of mastectomy, and that's available to you right now. Now, the first option is probably the most oldest one that we've had because our reconstruction has really had to follow the mastectomy techniques. The mastectomies have changed over the years, and originally we had radical mastectomies and then modified radical and then skin sparing and areolar sparing, and oftentimes now it's nipple sparing. So our reconstruction techniques have evolved. The first most common one that we've had over the years has been flap reconstruction, and that's simply taking a piece of tissue and moving it from one body area to another. In the past, we've done a treatment called a TRAM, which is transverse rectus abdominis muscle. And when you hear flaps discussed, they're often going to be discussed by the name of their circulation. And so originally, this was a muscle taken from your tummy here and moved up to build a breast. That has now evolved, and now you'll hear us talking about deep flaps, and that's DIEP, which is the deep inferior epigastric perforator flap. Again, that's the circulation, but it's still taking tummy tissue and moving it up and to create a breast out of that tissue. Now, you'll also hear things like pedicle and free. And the difference between that is that the pedicle is where we leave that tissue still attached to its blood supply and move it up. It's very much like a power cord that's being moved with it. When you hear a free flap, that means that it's disconnected free from the body, and then it's moved up into the area that it needs to be, and then the blood vessels are sewn together, and that's usually in a microvascular repair, and we often use a microscope for that. So it varies from person to person. Sometimes we do one side, sometimes we do both, and each person will determine what's the best course given their own body type. So another form of autologous tissue is actually fat grafting. And it's what we've always said in the past, right? Can't you just suck it here and put it there? Well, yes, we can. And so it's transplant, and it's an auto transplant, meaning we're transplanting from you to you. And so we don't have to worry about rejection. We don't have to worry about having to be on meds like organ transplant patients undergo. So it's very nice. Now, this can be used in two ways. It can be a standalone reconstruction all by itself. And this way, you do this serially over time. It's like if you're going to seed a yard, I want you to think about fat grafting like little tiny seeds that have to grow. What will happen is if we put and dig a hole and put all the seeds in that hole, they're not going to grow because they don't have contact with the soil. And that's similar to how we do in the breast. So typically what will happen is with a mastectomy, it's like pulling a pillow out of a pillowcase. You have the pillowcase there, but the pillow is gone and you have this big open space. If we put a bunch of fat graft in there that doesn't come with its own circulation, it's not likely to survive. So typically what we'll do is have the mastectomy, let that heal and recover, and then do serial injections every few months to build up the breast tissue to the size that we would like. This, of course, is limited by how large you are. If you're very, very thin, then this may not be a good option for you. But if you're not so thin, that might be a nice opportunity to relocate the fat to build new breast tissue. Now, the other thing that we often use it for is for revisions. And so whether you have an implant-based reconstruction or a tissue-based flap, you may still have some irregularities up in the upper pole and across the breast. And so many times, once we're about 3 to 6 months out from that original surgery, we'll go back and do a touch-up. We'll steal a little fat from somewhere and then we'll put it up across here. And the nice thing really is that it gives a very nice contour and it makes it look more smooth and more natural appearing, not so edgy. So we'll make that determination typically once the swelling in the breast area has recovered. Now the next reconstruction technique is implant-based reconstruction. And this can be in the form of a tissue expander or in the form of an implant. And it just depends on each patient. With a tissue expander, this is a temporary implant that can be filled with either saline or air, depending on the situation. And it allows us to stretch and grow tissue and create a space for an implant, maybe a few months down the road. Now, it's also used in flap reconstruction, basically as a placeholder. The tissue expander is holding in place where the flap would be. And this buys us a little time to get you through chemotherapy, but most importantly through radiation where that tissue changes. And so what we don't want to do is take a bunch of your own natural tissue, move it up and have a beautiful outcome, and then radiate it. This allows us to hold that place, get through your radiation, and then move all of that great tissue up and take the tissue expander out. It also allows us to stretch the tissue and create more room if you want to upsize. Now the techniques have really evolved because mastectomies have evolved, and now since we are doing so much with nipple sparing reconstruction, that space is already available to us. We have plenty of skin and we don't really need to grow extra skin. So what this does is this allows us to go to what's called direct to implant, or DTI. So direct to implant is where we can put the implant in right away. Now this often comes with other things such as absorbable material that helps hold that in place. It may include acellular dermal matrix, and these implants can be placed over the muscle or under the muscle, and it's different per patient. So we really will need to talk to you to figure out what's the best choice for you. And certainly if you've had breast implants in the past or currently have them, this really helps us as well. And so we'll talk about that in your consult as well. Overall, this could be a one and done. If you go direct to implant, you could theoretically at the end of that be done. Now in many cases I do find that patients have still a little bit of that edginess where you might be able to see just the edge of the implant, and so fat grafting is often a very nice add-on touch-up that doesn't require a whole lot of downtime. It's much different than the original mastectomy surgery, and it will just smooth that contour out and make it look very natural and very soft. So now that you know all of these different techniques, there's some other things that we need to consider, and that really is, what does the breast look like right now? How much droop does it have? Is it really large and do you want to go smaller? Or is it just really saggy and you want it more lifted? There are techniques that we can do that will help that, and we can in some cases stage it before your mastectomy and do that with a lumpectomy so that the cancer issue is completely cleared at the time of either the lift or the breast reduction, and then we allow that to heal. And the reason we like to do that is this will correct your shape. It also allows us to preserve your nipple and areola as much as possible. Now, if we did that procedure at the same time as your mastectomy, we would have to take the nipple and areola off as a skin graft and then put it back down on the tissue once it's all reformed as a skin graft. And one of the difficulties is it doesn't have its own circulation at that point, and it's going on tissue, the mastectomy skin, that has lost a great amount of circulation from having the breast removed. So you're putting a non-vascularized piece of tissue on a very low vascularized tissue and really hoping that it stays. And in many cases it does, but it doesn't always look the same. And so by correcting the shape before the mastectomy, we can do either a breast lift or a breast reduction if you're much bigger and you want to downsize. The nice thing is that you get that shape corrected. At that time, we do the lumpectomy. And we do the other side as well to match so that you look great. You no longer have cancer. We still know that you're going to have a mastectomy, but we're going to let that heal. And that allows the circulation to the nipple to really recover. So then that way, when we come back for mastectomy, whether it's a flap, whether it's an implant-based reconstruction, that shape is already correct, and we're just kind of swapping, the breast tissue for either the flap or the implant. And so that makes it much easier and gives a much better, I think, cosmetic outcome for that. The other interesting thing, one of the new things that we haven't yet talked about is resensation of the breast, and that's where we're actually adding sensation to the breast. Now, you're going to be missing a piece of the nerve because the nerve is in the breast tissue that's being removed. So now you have a little nerve over here and you have a nerve in the nipple and you have these two ends, but they're not connected. Well, now we have a graft. The nice thing is it's easier and it is more likely to work if we have those two ends. If we go from the end of the chest wall through the tissue and out through the tissue and then basically plug into the graft, you know, it's just more connections, and so you have graft going to graft. So the more natural you that's healthy, the better that it is, and the more likely that you're going to be able to get that nerve graft to heal and have better sensation. So either way, these are good options and we can do it, but I feel like the safest and the best cosmetic outcomes are often done with very droopy breasts in a staging manner. So the last area that I want to talk about is how do we do reconstruction for women who have really, really wide chest. And this presents a little bit of a difficulty because the implants that we have available to us are of a set diameter, and so they don't exceed that. So if you are very wide across the chest width, and we call it breast base width, and that's this across here, and so we'll measure it in your consult. Now the issue is if your width is much wider than you have an implant available, then it's just too narrow, so it doesn't look good. And whenever you're doing implant or even flap reconstruction, you've got to hit that width just right, because if you're too wide, you get all this fullness in your armpit and it rubs, and you don't like that. But the other thing is, if it's too narrow, then it just sags forward and it doesn't look like a natural breast. So we have to be very thoughtful about that. So in some cases, implant reconstruction as well as flap reconstruction are really not a good choice at first. And so typically what we'll do is do a staged reconstruction called a Goldilocks. And what that is, I like to think of it of like vest over pants when you think about a suit. The thing is that typically the breast tissue, there's a lot of skin available. And when that mastectomy tissue has been removed, you have this loose bag of skin. And what do you do with that? Well, normally, if you were just having a traditional mastectomy with no reconstruction, that tissue would be removed and you would be flat. But what we like to do is use all of that lower pole skin that we would otherwise be getting rid of and lay it down onto the chest wall to help auto-augment that area, and then the upper skin goes over top of it. So that way, you end up not being concave. It's really nice because it gets us a jump start into reconstruction. And usually at that point, what we'll end up doing is fat grafting. And that may be a whole course of fat grafting where we build the entire breast out of fat, or it may be a bridge to implant-based reconstruction, because if we can get fullness around the perimeter and certainly in the center, but really building up, then the implant needed, that width can be more narrower and you can still have a very nice outcome. And so this will simply be a bridge to the next step, and it will be a personal choice, which we'll talk about in our visit, but we'll be able to decide and customize exactly what you need and what fits with your desires as well. Now, the last part of reconstruction that I want to talk about is very exciting, and this is really new and cutting edge, that really takes us to the next step. And really, when we talk about mastectomy reconstruction, we would like to have a comprehensive restoration. And so the thing that we've been missing for so many years is sensation. And we've always told patients, what's going to happen is you're going to have this, you'll have a beautiful outcome, but it's going to be numb. It's going to feel heavy, and that's what the sensation of numbness is. And certainly if you've ever had any dental work done and your face is numbed up, it feels like your face is falling off. Well, that numbness eventually goes away with dental work, but in a mastectomy it doesn't, and that becomes our permanent status. And so now we have available to us nerve grafts. And so nerve grafts are like a bridge that connect the two ends of what's left over after the mastectomy. So the sensation to the chest wall, it comes from many nerves along the side, and the sensual sensation that we have in nipples comes from the fourth intercostal nerve. But there's many intercostal nerves also there supplying the breast itself. So we have a pressure sensation, we also have a sensual sensation. So one of the things we want to try and do is connect those up. Well, now there's a nerve graft that is available to us. So at the time of mastectomy, your general surgeon will work with us and help dissect those nerves out. And once we find them, we'll be able to connect this little nerve graft and go into either the nipple nerve itself, if we can find it, but you can't always find it. And so one of the other techniques we do is called arborization. And so the nerve has lots of fascicles, and we're able to split them out and then sew them in, just like a tree having all these little branches. And so we'll put some in the nipple and some along the areola, and this will help deliver as much information sensory-wise to that area, so that hopefully down the road you might be able to have some nipple sensation or areolar sensation. The most important thing that we're really trying to get is protective sensation. And so one of the problems that we encounter is when this area is numb, you don't know when it's injured. And so you could cut yourself, you could have an infection, you could, I had a patient who dropped a curling iron and didn't jump as we all would because she didn't feel it. And so she pulled it out, and then she noticed that her breast was lots of little curling iron burns, kind of like our foreheads. So we got to be really thoughtful about sensation. If you'd like to know more about that, there's a great website called resensation.com that kind of goes over that a little bit more, and you can look that up and watch a little bit more and investigate a little bit more to see if this is right for you. But we definitely recommend this because the more protective sensation that you have, the safer it will be for you. So that's pretty much the gamut of breast reconstruction. Now, what I'd like for you to do is write down your questions so that way I'm looking forward to seeing you in your consultation. Let's go over those questions, and then we can really decide which option is right for you.